Hello and welcome to Whiteboard Learning. This is going to be about blood pressure. And then the next section, we're going to have a small video on blood pressure management and what the drugs do, specifically to talk about when you're under anesthesia. But let's talk about blood pressure. So we learned last time what pressure is, and basically we're talking about your blood pressure. So there's a system, and it is a collection system, which is the venous section, and it is a pump section where we also get oxygenated. So we're going to call it just one pump, so that's the heart. And then we have the delivery system, which is the artery. And then we have capillaries, all kinds of capillaries as we go along here that collect blood and then bring the oxygen to the cells. So bad spelling, bad writing today, huh? So artery, capillaries, vein, heart, just this circuit. So where are we measuring pressure? We're measuring arterial pressure. So we learned about systolic, when we learned about mean, and we learned about diastolic, right? So these are the different phases of heart pumping where the pressure is different. In systolic, it's the highest, diastolic, it's the lowest, and mean is about a third of the difference of the two up from diastolic. Mean is thought to be more representative of your delivery pressure over time because it's sort of the average pressure. So we're going to talk about mean pressure, but you might be measuring systolic pressure, and that's okay when we talk about still the things that affect it. But let's talk about pressure. So mean pressure, arterial pressure. What determines mean arterial pressure? Well, that seems to make sense if you think about it in terms of the things that are doing the work. The heart is pumping against a tube, and the tube is not completely an empty hole, right? It's not like you're pumping water into a hole. You're pumping the fluid, the blood, into somewhat of a stiff artery. And the stiffness remains all the way down until you get to the capillaries. And these arteries have muscles that can contract and relax. So it's the heart pumping versus the resistance that these arteries may or may not give you to the pumping. And that is the first equation to think about, is cardiac output times vascular resistance. And we like to talk about it in this case, systemic vascular resistance. Now, what makes up those things? Well, that's relatively simple to think about with cardiac output. Cardiac output is made up of how much you pump, or stroke volume, SV, times the heart rate, how many times you pump. That seems to make sense, right? How much you can pump in mils, how many times you can pump. So cardiac output. Now, what determines stroke volume? Well, stroke volume can be related to the volume of blood returning to the heart. That's a preload, meaning it is preloaded before the pumping. And that's determined by the system, the venous system, how much fluid is returning. And then you might also have to have a volume in here already that you're pumping against. It's not taking into the resistance of the arteries, but the volume that you're pushing against, and that's afterload. We don't talk about it that much with low blood pressure, but you can talk about it a lot with high blood pressure. And then contractility, how well the heart can actually pump. And so, certainly if the heart can't pump very well, like with dilated cardiomyopathy or with sepsis, something like that, then certainly you're not going to get very much volume being ejected from the heart. So that makes sense for those things. Then how do you affect systemic vascular resistance? Well, you can either dilate or contract, right? So what are some certain things? Let's talk about things that affect these systems. So dilating might be like, say you have anaphylaxis or a drug reaction. So some sort of histamine could be as well for mast cells. And you could also have sepsis do that. So those are some different systems that can do that. Or you might have contraction. So normally when you lose blood volume, your body, this is a natural response. So that's related to catecholamines or stress hormones that cause your body to contract. So contraction can be also from drugs, where you don't alpha 2 drugs, we talk about those, so that your periphery doesn't have as much perfusion. So it contracts that down really small. What about heart rate? What affects heart rate? Well, you can either be low, bradycardic, or high, tachycardic. And those things can be determined by how much volume your blood seems to think they have. So if preload goes down, you want to preserve cardiac output, you might increase heart rate. So those things should come together, or there's something probably going wrong. So you could have drugs, you could have a heart problem like block that creates a situation where your heart rate is low, any of the blocks. You can have tachycardia from pain, you can have low volume, you can have a drug that induces tachycardia either on purpose or not, like ketamine is not necessarily trying to increase heart rate, they're trying to induce anesthesia. So heart rate and stroke volume are somewhat, if you think about it in an adaptive sense, almost opposite, right? If the stroke volume goes down, you want the heart rate to go up and reflexively, and that can sometimes give us some hints. So what can affect contractility? Well, drugs can, and diseases of the heart, like DCM. You can also have HCM. You can have sepsis, can affect the contractility, and preload is usually volume changes, but it can also be that the venous system can dilate too. So what if suddenly the venous system is holding a lot more blood than it used to? Or what if there's an occlusion? So let's say there's a big old blown up stomach here from a GDV. So that could be also occlusion or increased venous capacitance, meaning there's more volume in it. So certainly if you think about all of these adaptive measures, you can start to think about some of the drugs that you might use to affect blood pressure, because you can come at it in so many different ways. You can address preload, you can address contractility, you can address heart rate, you could vasoconstrict the periphery. So when we talk about blood pressure, either lowering or if it's hypertension, or raising if it's hypotension, there are places that you can work. So let's say, for instance, you have high blood pressure. You might not want to lower cardiac output on purpose unless you have a tachycardia, because tachycardia could be bad. But you really wouldn't think about becoming hypovolemic on purpose or reducing contractility on purpose. But maybe like in a hyperthyroid cat who's tachycardic, maybe you would give what's called a beta blocker, and a beta blocker would help slow the heart rate down. So if they're hypertensive, you can bring it down. Those are usually momentarily hypertensive pets, but you could also think of doing that with a chocolate dog. When you're doing that, you got to bring down that heart rate, so that if you have any hypertension, or treat pain with pain meds, your heart rate comes down and you don't have hypertension. Hypertension could also be caused by increased preload. If you volume overload a pet, that's one of the things we think about a lot of times, but isn't always true, because the kidneys are pretty smart and help us out. But in a very acute setting where you say you gave a liter to a cat, preload might go up, blood pressure might go up, because you can't get the heart rate down too much. So most of the time with hypertensive pets, where we'll work on the equation is on the resistance, and we'll work on medications like ACE inhibitors or amlodipine that dilate the periphery so that the blood pressure comes down without changing cardiac output too much. And then with hypotension, we can think about drugs that work as well to increase contractility and to increase rate, and then cause vasoconstriction. And that's what the next section is going to be a little bit about, is how to deal with hypotension.